Okay, Assalamualaikum warahmatullahi wabarakatuh, and good evening to my friends and respected doctors. So today, my name is Arish Nazwa. I will be presenting a title of Intestinal Obstruction in Children. So my supervisor is Dr. Au Mei Yi. So first, let me know about a definition of the intestinal obstruction. So intestinal obstruction is a blockage that keeps food or liquid from passing through to large intestine. So it can be classified to two main pathophysiologies, either mechanically, obstructed mechanically, or functionally. Okay. So before we go deeper, so basically obstruction can happen anywhere along the GI tract. So it can be from esophagus. Okay, if it happen in esophagus, we call esophagus such as esophageal atresia. If happen in stomach, maybe hypertrophic pylori stenosis. If happen in duodenum, such as duodenal atresia or stenosis, malrotation, and volvulus. If happen in small intestine, it can be jejunal atresia, hernia, or amphilomesenteric. And it can be colonic atresia, meconium plaque, small left colon syndrome, or even Hirschsprung disease. If it happen in rectum atresia, if anus, perforated anus. So because these children, so the presentation will be differ based on age. So if neonates, which is less than 1 month old, okay, for mechanical causes, for mechanical disease such as pyloric stenosis, intestinal atresia, malrotation, volvulus, perforated anus, incarcerated hernia. If functionally, usually because of NEC, Hirschsprung disease, septicemia, or hypothyroidism. Okay, so for infant from 1 month to 3 month old, okay, usually intussusception takes place, which is from 3 months to 3 years old. And then quite also happen is malrotation with midgut volvulus, and then incarcerated inguinal hernia and microdervaticulum. Okay, if preschool age, less than 5 years old, either intussusception, incarcerated hernia, and perforated appendicitis. If school age children more than 5 years old, maybe IBD, and then is intrinsic lesions such as polyps, masses, or merkel diverticulum, or extrinsic compression from the incarcerated hernia, perforated appendicitis, or post-operative adhesions. Okay, so we go to how usually babies or children with intestinal obstruction are presented with. The most frequently is vomiting. Okay, it can be either bilious vomiting or non-bilious vomiting or delayed vomiting. If bilious vomiting, usually because of obstruction distal from to the D2 lah. If non-bilious, obstruction proximal to the D2, and delayed vomiting usually from the large bowel obstruction. So usually infant who was eating well then suddenly vomit bile, okay, we must suspect volvulus or malrotation until proven otherwise. Okay, so the first presentation is vomiting. Okay, and is alert macam is something to be alert if it is bilious lah. Okay, and then they can come with also feeding intolerance, abdominal distension. Okay, abdominal distension like central abdomen distension is low of the small bowel obstruction, and distension is much less in higher small bowel obstruction. Okay, and then constipation. So that's why we need to know the BO frequency, and if still can passing flatus or not. And then can also present with delay passing out meconium in neonates. And lastly, can come with abdominal pain. However, in babies, they just cried lah. They didn't tell they are in pain. Okay. So for physical examination, as usual, we must see first the general appearance. if the patient conscious of irritability, and then if he or she lethargy or weak, and then any abdominal distension, obvious abdominal distension, confusion ke, hematochezia, and then because this is pediatric patient, we also must noted dia punya height and weight and head circumference. Okay, especially the weight, because we need to calculate for the IV drip and the medication after that. And then check for the peripheries, sign of dehydration lah. Especially we can look from the capillary refill time, dry tongue. Okay. Alright. So it's important to know dehydration sign in children. We can see from general appearance first. Okay, either the patient is alert, restless, or drowsy. Okay, this will tell how much dehydration is the baby lah. Okay. Okay, kalau baby tu still neonate, and then kita boleh tengok anterior fontanel dia lah, either normal, sunken or very sunken. And then boleh tengok juga eyes, because and then respiration will be rapid in some dehydration, and we can also find cosmal breathing in severe dehydration. And then for blood pressure, slightly decrease towards hypotension in some dehydration, but will be hypotensive or even unrecorded for severe dehydration in children. And then CRT, of course, will be more prolonged in severe dehydration. Look for skin turgidity, it will be reduced in dehydration. And to monitor the dehydration status, we can also look for the urine output. It will be reduced in urine output, and if it's severe, it will be markedly oliguria. So we can also, then we can proceed to abdominal examination. So because of there is obstruction, the stomach will be distended. And then you must also look carefully on the stomach if there's any scar. Okay, we evidence of previous surgery lah. And then any visible peristalsis. And then any skin discoloration lah. Usually in NEC, dia punya discoloration dia akan redness kan, very redness, and then pain kan. Okay, and then kita tengok juga inguinoscrotal swelling for hernia, and then ada guarding, symptoms of peritonitis kan, and then bowel sound, is it absent or sluggish. Okay, signs of peritonitis is guarding, rebound tenderness, rigidity. Then must proceed to look for the digital rectal examination. If the anus is imperforated ke apa, kita kena tengok juga, pastikan the anus is not imperforated. And then presence of bloody stool ke, or red jelly light ke, and then recurrent jelly stool kan, in interception, and meconium and gush of air in Hirschsprung disease. Okay. So this is intestinal malrotation lah. Okay, if you can see on the left picture, the actual position of intestine. However, for the right picture is malrotation happen. It's congenital lah. Okay, di dalam perut mak lagi dia punya intestine dah malrotation. Okay, not in the not in the proper position it should be. So intestinal malrotation, if it twisted, then it can be volvulus lah. And then it is a very dangerous lah, volvulus. Okay, this is micral diverticulum. It's quite rare, 2% of population, located within 2 feet from the ileocecal valve. The length is 2 inch, usually symptomatic before age of 2. Okay, there are 2 type of common ectopic mucosa, gastric dengan pancreatic. Okay, usually happen in male lah, 2:1 ratio, male to female for symptomatic lesion. Okay, then ada diagnosis when patient come with IO, intestinal obstruction, can be also because of acute intussusception. It occurs when one portion of the gut become invaginated within the immediate adjacent of the segment. Usually happen between small intestine and the large intestine. They are meet when the segment when they meet lah. So the small intestine invaginated into the large intestine lah. So it common from 3 months to 3 years old, 3 years of life lah. Okay, and then common after viral illness, and then become enlargement of the Peyer's patches, and then ileocolic is the common variety in children. Okay, alright. So interception, if you can see on the picture on the left side, ileum telescopic, okay, dia masuk inside the ascending colon, the ileum part from the small intestine, telescope into the ascending colon. Okay, so this cause the obstruction lah, and then inflammation happen, bleeding happen, red current jelly stool. And then how it's become dangerous because of blood vessel will become trapped in between the layers. So decrease blood vessel punya flow, blood flow, edema, strangulation of the bowel, and then gangrene. Then can go to septic shock and death lah. Okay, so usually they will presented with colicky pain dengan vomiting lah, milk then bile. Okay, in between episode, children usually appear well. Later, dia boleh keluar dia boleh presented with current jelly stool. Okay, here NEC punya appearance on the left side, grossly distended, shiny, erythematous abdomen in necrotic enterocolitis lah. Okay, that's the skin discoloration. And then on the right side, ada inguinal hernia, inguinal scrotal hernia, and then huge acutely obstructed inguinal scrotal hernia. That's how it looks like. Also can cause obstruction. So we must investigate more. First, we must go with blood investigation, FBC lah. You look for HB, hematocrit, white cell count. White cell count to look for any infection, and then look for anemia as well. Then look RP lah, kita tengok AKI, and then electrolyte imbalance. Because all these things must be settled first before management like surgical intervention. Okay, then VPG, they represent with acidosis from bowel ischemia ke, then alkalosis ke because of vomiting, because of continuous vomiting kan. Usually more to pyloric stenosis in children. They will have projectile vomiting. And to radiological examination, from erect chest X-ray, we must rule out any air under diaphragm, and then or any aspiration pneumonia. Okay, from abdominal X-ray, you can see a lot. After this, I will show some X-rays of abdomen, ultrasound abdomen, and contrast study. All this can help lah. So on the left side is normal abdominal X-ray. However, when there's obstruction, you can see there the abdominal X-ray become having a lot of dilated bowel lah. Okay, And then this example of necrotic enterocolitis lah. It usually happen in premature baby. 7% in premature baby. They have the stage we call Bell stage. Okay, for the diagnosis lah. And then other than that, we can see from the abdominal X-ray for NEC, they will have, if it's severe lah, it will have pneumoperitoneum. Okay, this one pula double bubble sign for duodenal atresia. So if distal to the ampulla of Vater, it will bilious vomiting kan. So we must watch out for bilious vomiting juga. And then this is hypertrophic pylori stenosis. Hypertrophic pylori stenosis is abnormal thickening of the pylorus. Okay, the muscular sphincter in our stomach, at the end of our stomach tu. So when it's hypertrophic, it's narrow the passageway. So on the chest X-ray, we can see distended stomach. And then there's another X-ray then yang kita boleh nampak macam caterpillar sign, where ada dilated distended stomach and gas in the small intestine, which macam nampak caterpillar sign lah. Okay, so this from ultrasound and contrast juga boleh tengok. Okay, this one is interception. So as I told earlier, interception is telescopic of one segment of the intestine into another, usually between small and large intestine. So it will present with pain of the abdomen, and then later can have rectal bleeding, red jelly-like stool, and of course we present with vomiting as well. So we can see there, dia macam ada bullseye punya presentation on the abdominal X-ray. We can also diagnose from ultrasound. Okay. Other than that, we can also do CT abdomen, barium enema or air contrast enema lah. For initial treatment, kita boleh try liquid contrast enema or air contrast enema. Dia punya successful rate dia quite tinggi, 60 to 70%. If unsuccessful, then we can go to surgical intervention lah. Okay, this one is intestinal malrotation becoming bubbleless lah. As you can see there, twisted. There's a twisted. Okay. So usually they will present it with cramping of the feeling of cramping of the abdomen. If baby, they will pull up their leg and crying lah, and also come with also vomiting, non-stop vomiting lah. Then this is an example of abdominal X-ray of Hirschsprung disease. This happen when absence of nerve cell, ganglionic, in a segment of bowel. So when muscle lose ability to move stool through the intestine lah, where peristalsis cannot happen, so they can defecate. So usually we can it will presented with fail to pass meconium within 24 to 48 hours of life. The definitive diagnosis must be done through full thickness of rectal biopsy. We must take biopsy to diagnose Hirschsprung lah. So to be diagnosed is intestinal obstruction. The first thing first, we must do resuscitation. Make sure the patient is not in shock, semua tu lah kan. So first we must see the airway lah, must pattern airway, and then look for the breathing. If SpO2 drop ke apa, kita kena try to give oxygen supplementary if needed, and then start to give IV line lah, 2 large bore kena set up, and fluid resuscitation if needed, 10 to 20 mg to 20 ml per kg Hartmann bolus, and maintenance concurrently lah. And then next, we must keep the patient near by mouth. And then because there's obstruction, they can't take the food cannot come out, so we need to insert rice tube, free flow, and aspirate. So for gastric decompression. And then to monitor the monitor IO, and then start broad spectrum antibiotic. Usually we start maybe IV unacin 50 mg, 50 mg per kg, and then correct the electrolyte imbalance. Okay. If the patient coming with severely dehydrated, we need to refer pediatric medical lah. Okay. Make sure close monitoring, watch out for some symptom of peritonitis, bowel perforation or hypovolemic shock. And because they are children, they must be consented by their parents we must counsel their parents regarding the child condition. So, what indication for emergency laparotomy? First, malrotation with or without midgut volvulus. And then when we suspect pneumoperitoneum through abdominal X-ray. And then presence of irreducible intussusception and peritonitis. So before we go for laparotomy, make sure there is a GSM lah for babies. Okay, thank you. Is there any question?